So hello and welcome to this first podcast of 2009 on pyelonephritis. During this podcast I want to talk about the important definitions and what differentiates acute and chronic pyelonephritis. I want to talk about the most important causes and the pathogenesis of the condition, then talk about some of the clinical features, and finally consider important management principles, that's the investigations and treatment. Acute pyelonephritis can be defined as acute inflammation of the renal parenchyma and renal pelvis. This should be contrasted to chronic pyelonephritis, which represents more long-standing, recurrent or persistent inflammation of these structures. Pyelonephritis is common and is something that as a junior doctor you'll see both in the emergency department and on the acute medical take. It affects all ages, but importantly is particularly common in young women. As already suggested, it's more common in women than in men, and this is because of the most common ascending route of infection through the urethra, bladder, up through the ureters and then to the kidney. Females are more susceptible to this type of infection because of the relative shortness of the urethra compared to the male and the proximity of the urethra to the vagina, perineum and the anus. The most common organisms that cause pyelonephritis are gram-negative organisms from the bowel, and these include, importantly, E. coli, Klebsiella, Proteus, Pseudomonas, and Serratia. You'll sometimes hear mentioned, however, the hematogenous route of infection of the kidney. This is quite rare, but can occur in the setting of endocarditis, where there is embolism of bacterial material deposited on the heart valves that travels through the systemic circulation and lodges in the kidney. It can also occur in the setting of renal or perirenal abscesses. Some textbooks will still talk about the lymphatic route of infection for the kidneys. However, most current evidence suggests that this is not an important route of infection. So let's move on now to talk about some of the important risk factors for the development of pyelonephritis. As I've already mentioned in the epidemiology, an important risk factor is being female for the reasons outlined. Other risk factors can be broken up into constitutional and physical. By constitutional, I mean things that increase susceptibility to infection in general, such as diabetes or immunocompromise. And by physical, I mean actual anatomical abnormalities within the urinary system that predispose to infection. Important examples of these would be congenital anomalies such as horseshoe kidneys or duplex ureters, very importantly urinary calculi or stones, and finally the presence of indwelling catheters. It is also important to note that cystitis or inflammation and infection of the bladder itself is a risk factor for the development of pyelonephritis, and this is because edema within the bladder promotes dilatation of the vesico-ureteric junction and hence further ascension of infectious material. When considering the important clinical features, you should try and break these up into symptoms and signs, and for each of symptoms and signs you should try and break things up into general and specific. In terms of the general symptoms, patients tend to present unwell with fevers, headache, and very commonly vomiting. A lot of patients will also have loin pain or back pain, and also have urinary symptoms such as frequency, dysuria, and urgency. Try and remember to ask about loin pain and back pain in all patients who you suspect of having a simple UTI. In terms of signs, the patient will often have a temperature, and this temperature is characteristically swinging in nature. They may have manifestations of pyrexia such as rigors, and they also may have degrees of dehydration, perhaps secondary to vomiting or excessive fluid loss because of the increased temperature. On abdominal examination, they may have loin tenderness. This is particularly apparent in the renal angle, and may also have coexistent suprapubic tenderness. However, there are some important differential diagnoses that need to be excluded in all patients who you suspect of having pyelonephritis. You should always consider appendicitis, so look for tenderness that's most prominent in the right iliac fossa. You should consider ectopic pregnancy, and therefore all patients who present or are of the right age should have a pregnancy test. You should also consider pelvic inflammatory disease in patients presenting in this fashion, and some people would advocate performing a pelvic examination. You should also consider the presence of renal colic, cholecystitis, and even lower lobe pneumonias, and in males, testicular torsion, as pain from the testicles can radiate up into the abdomen. When thinking about the important investigations for pyelonephritis, you should try and have some sort of structure so that you can recite these investigations. The structure I like to use consists of about 5 modalities. This includes cultures, bloods, imaging, scopic or biopsies, and finally functional or special tests that are specific to a particular organ system. In terms of cultures, you want to think about urine, and obviously you'll want to do, as we've already said, a pregnancy test. You'll also want to think about doing a urine dipstick, as patients often have a coexistent UTI. The signs on a dipstick will be positive nitrites and leukocytes. If the urine dipstick is positive, you'll want to send the urine for culture. If the patient is pyrexial, you should also think about performing blood cultures. Venous bloods are obviously going to be important, and you'll want to do a full blood count, user-nees, and a CRP. However, you need to be able to justify why exactly you would do these investigations. You do a full blood count to look for leukocytosis that would be associated with infection. You perform a CRP as this is associated with systemic inflammation. And finally, you consider doing urea and electrolytes in order to clarify the patient's renal function and also to consider their hydration status. In terms of imaging, you'd want to importantly perform or eventually perform an abdominal and pelvic ultrasound in order to exclude the presence of any congenital anomalies or the presence of a stone. And you could also consider doing an X-ray of kidneys, ureters and bladder, as many ureteric calculi will show up on this film. In terms of scopic and biopsy, there aren't any particular tests to perform. And finally, if you're interested in kidney function after perhaps the infection has cleared, you can consider doing DEMSA and MAG3 scans. However, this is much more important in children. Finally, let's talk very briefly about the management of pyelonephritis. The minority of patients with mild pyelonephritis can be managed at home with oral antibiotics. However, most patients with systemic evidence of disease need to be admitted to hospital. As always, you can divide our management into conservative, medical, and interventional. If the patient is dehydrated, you're going to want to consider giving IV fluids. If the patient is in pain, analgesia. And finally, because as we said, vomiting is very common in pyelonephritis, you might want to consider giving an antiemetic, such as cyclizine or metoclopramide. The cornerstone of medical management is, of course, antibiotics, and you'll want to give a 5 to 7 day course of antibiotics. Regimes vary via hospital, but important examples include ciprofloxacin, gentamicin, and cephalosporins. Finally, on the interventional side, if the infection is related to obstruction, perhaps because of a urinary calculi in the ureters, it may be necessary to insert a nephrostomy into the ureter in order to relieve any pus or buildup of pressure within this structure. Most patients that you'll see with pyelonephritis are young and otherwise fit and healthy and will do very well. However, it's important to be aware of 2 complications. The first is urosepsis, which is a kind of broad term that we use to describe a situation where patients with infection within their urinary tract develop bacteremia and septic shock. This is most often seen in the elderly, but can be quite nasty and necessitate admission to the intensive care unit. The other condition that it's important to be aware of is chronic pyelonephritis, where infection never completely clears with each course of antibiotics. This is important because eventually it can lead to renal impairment and the need for renal replacement therapy, such as dialysis. So thanks very much for listening to this first podcast of 2009. This year is going to be, I hope, quite an exciting year for Podmedics. We've got lots of interesting things planned. So keep your eyes glued to these podcasts and the website, podmedics.com. See you soon.